Once again, good morning, everyone. I was asked by Peter to give a presentation on inferior vena cava filters. And a couple of years ago, I had given this presentation to another grand rounds based on some increase in litigation cases. But I think it's a good opportunity to review indications for inferior vena cava filters, what the literature says, what are the current trends, and then what are some of the potential complications and how can people, apply inferior vena cava filters appropriately and try and avoid complications of their use. So make sure that there we go. I have no disclosures about this. So deep vein thrombosis affects about 600,000 new people every year in the United States. It's a very common occurrence. The recent pandemic further increased the prevalence of deep vein thrombosis, as most of you are aware. Looking at one county, the Olmsted County is where Mayo Clinic is. They reported that there are at least 201,000 new cases of VTE annually in the United States, 30% of which result in patient demise within 30 days. Not as a primary cause, but a lot of them appear in patients that are in terminal cancer and everything. So 30% of the patients that will be newly diagnosed with a DVT will die within 30 days. And 20% of them will suffer sudden death because of pulmonary embolism. And this is an autopsy picture of a fatal pulmonary embolism. You see the confluence of the two pulmonary veins here and the saddle embolus, right in the middle of the picture. Sometimes we're looking at complications that are even more rare. What you see here captured in an echocardiogram is a vein thrombus passing from the right atrium to the left atrium through a patent foramen ovale, and that thrombus was afterwards retrieved, as you can see here, from the patient's lower extremity after it caused a paradoxical embolus. So when a patient is diagnosed with a VTE, the goals of therapy are essentially to prevent thrombus extension, to prevent death from pulmonary embolism, and then to prevent recurrent venous thromboembolism, because that is associated with further deterioration, sometimes resulting in chronic venous insufficiency and post-thrombotic syndrome. So the treatment options for VTE are anticoagulation. This is the first line of therapy. A number of different agents now for therapeutic anticoagulation on patients with VTE. The classic paradigm was a short course of heparin and then transition to warfarin. Now we're much more liberal, using low molecular weight heparin as a treatment line, and the anti-10A drugs, Xarelto, Eliquis, are first. The thrombin inhibitor drugs such as Xarelto and Eliquis, who are first line of treatment right now. Interventional treatment in the form of endovascular interventions are catheter-directed thrombolysis, mechanical thrombectomy or aspiration, and then a combination of them, the pharmacomechanical thrombolysis. The reason for reverting to these types of therapy are in younger people to prevent organization of the thrombus, obstructive phenomena, and transition to post-thrombotic syndrome, or sometimes in rare occasions when the patient's limb is threatened by phlegmasia, then endovascular treatment or surgery in the form of thrombectomy and embolectomy are required. Cable interruption has been around for over 70 years, and the idea of cable interruption is to prevent fatal pulmonary embolism in these patients that cannot receive therapeutic anticoagulation. So a little bit on the history of cable interruption. It was first introduced as a barrier to embolization by Trousseau back in 1865, and Homans in the 1930s introduced femoral vein ligation as a means of preventing pulmonary embolism. Osner and DeBakey moved further up and ligated the IVC in patients that were at risk for pulmonary embolism. And back in the 1950s, a vascular surgeon at Rochester, New York, Jim DeWiss, introduced the IVC clips. When I came to this institution about 15 years ago, I opened a tray, an abdominal tray that was very old, and I did find one of these IVC clips where the clip was placed across the inferior vena cava and was left there permanently. The need for a different means of inferior vena cava interruption was evident, and in the 1970s, several devices started arising. The Mobenuden umbrella was the first one that was introduced in 1970, but in 1973, Dr. Greenfield introduced the famous Greenfield filter. It was a conical shaped device filter that was introduced through a very large sheath, a 29 French sheath. Gradually, and in the 1980s, the filters started becoming a little smaller in terms of delivery systems, and now we went on to percutaneous interventions. And one of the major advances that happened in 2003 was the introduction of retrievable filters. So some of the characteristics of the ideal inferior vena cava filter: it needs to protect, obviously, from emboli. It needs to provide effective filtration of emboli. It needs to allow the inferior vena cava to be patent, even after the filter captured some of the thrombus. It should have minimal tendency towards propagation, and it should have a very low risk for inferior vena cava penetration. I'm putting all of these things there because, as you see, some of the new designs may not necessarily adhere to these standards as well. I don't want to bother you a lot with hemodynamics, but this schematic here shows how a conical design filter, even if it captures a significant amount of thrombus, can allow blood in the periphery and maintain patency of the inferior vena cava. And a little bit more of a schematic here where you see two different filter designs: the Greenfield filter on the top, where the flow from the sides after it has captured thrombus is much more brisk, and then the trapeze filter, which once it captures thrombus, it appears to have an area right on the top of the filter there that may be vulnerable to further thrombosis. And we know that because looking at the MODE database, the thrombosis with the Greenfield filter of the inferior vena cava are significantly less compared to those reported with the trapeze filter. So when to put an IVC filter? There are absolute indications, there are relative indications, there are prophylactic indications, and we'll go through those little by little. So an absolute indication is a documented VTE that involves the veins from the popliteal and more centrally, an inability to anticoagulate. When you have recurrent pulmonary embolism while the patient is on therapeutic anticoagulation, that needs to make certain that the patient is compliant and that if he is on a Coumadin regimen, that at least 2 consecutive INR values remain therapeutic. Otherwise, it cannot be considered as failure. The other situation where you need to seriously consider an IVC filter insertion is when somebody presents with bleeding, which requires discontinuation of anticoagulation. He's in the acute phase of a proximal VTE. There are some relative indications. Some of them are not considered indications anymore. Iliofemoral DVT with free floating thrombus. I think that a lot of us these days, will treat these patients with anticoagulation. Aseptic PE, chronic or recurrent pulmonary embolism in a patient who has pulmonary hypertension. The idea here is that these patients will not be able to tolerate even a smaller pulmonary embolism, and you want to prevent that. A lot of the PER teams will recommend placement of inferior vena cava filters in patients that had large or unstable Ps and they were treated with anticoagulation, because these large unstable Ps can get quickly deteriorated even with a small embolus and result to death. There's been a lot of discussion on prophylactic use of inferior vena cava filters. A decade ago, it was a very prevalent thought process that patients who are morbidly obese or have a pelvic malignancy, or patients that have orthopedic and spine surgery or multi-trauma, they should have a prophylactic IVC filter placed prior to surgical interventions. And that was a mode of prophylaxing them from pulmonary embolism. Another prophylactic indications are patients who have lower extremity DVT that are candidates for thrombolysis, and the idea was to place an IVC filter to prevent pieces of thrombus breaking off during the thrombolysis process and causing pulmonary embolism. Now, let me give you a little case scenario here. These are all cases, that were being consulted. This is a 57-year-old female who has debilitating back pain, who developed left common femoral, and popliteal DVT 3 days after spine surgery. So the question here becomes, what are the treatment options on this patient? And I listed some there. SCDs and surveillance, intravenous anticoagulation with or without SCDs, low molecular weight heparin with or without SCDs, some of the new novel anticoagulants, Xarelto, Eliquis, any type of anticoagulation plus IVC filter or IVC filter only. So I will limit this to the last two choices, and let me see a raise of hands, if how many would consider just an IVC filter for appropriate treatment of this patient? I don't know if we have a way to show hands. Yes, we do. So anyways, the correct answer here is you got to discuss this with your spine surgeon. 3 days usually after spine surgery is still in the early phase that a lot of the spine surgeons, depending on the extent of the procedures that they did, may not want to proceed to full anticoagulation. If you cannot fully anticoagulate this patient, then you need to definitely prophylax them with an inferior vena cava filter. If you can fully anticoagulate them, then the filter is not necessary. Somehow, there we go. So this is an old trial, the PREPIT study, that looked at the scenario where patients were getting an IVC filter plus anticoagulation versus anticoagulation alone. And what this study indicated, that those patients that had an IVC filter inserted in addition to the anticoagulation had a lower rate of pulmonary embolism, but at the expense of a higher rate of recurrent DVT. However, the patients that had anticoagulation only had a slightly higher rate of pulmonary embolism, but a lower rate of recurrent DVT. Historically, IVC filters were rather rarely utilized until the early 2000s. That's when the retrievable inferior vena cava filters were introduced in the market. Between 1999 and 2008 in the Medicare population, there was an exponential increase in IVC filter utilization. It was over 100% increase in placement. And by 2012 estimates, there were 224,000 inferior vena cava filters inserted in the United States annually, compared to only 9,000 in the Europe's big 5 countries, which have about the same population as in the US. So that was a dramatic difference across the Atlantic. And the interesting component in these two populations, there was no real difference in VTE-related deaths. So why did we see that increased use of filters in the United States? One was, as I mentioned before, the introduction of retrievable filters. The approval by the FDA was in 2003, and that gave a false sense of security to the people that, well, I'm inserting a filter. It's not necessarily something that's going to stay there permanently. So it's a good option. We developed options for bedside insertion using ultrasound guidance. And then in 2002, I'll show you later, the East Trauma Guidelines gave a big push to the use of inferior vena cava filters for patients with multiple trauma. Well, we shouldn't necessarily keep the reimbursement out. Up until a few years ago, inferior vena cava filter insertion was paid at the same rate that caval interruption, the open procedure where you were putting the clip on the inferior vena cava, was reimbursed back in the 70s. So those things created a nice environment. And then, of course, the medical legal environment here, where any death from pulmonary embolism, becomes, as I'll show you later, a focus of litigation. That increased the temptation to use these devices with increased frequency. These are the East guidelines, the trauma guidelines that I mentioned before. And if you see there, on the black line at the bottom, it says that insertion of a prophylactic inferior vena cava filter should be considered in very high-risk trauma patients who cannot receive anticoagulation. Now we've gone a little too far in this patient population. And this study here completely challenged, this notion by the East. They showed, that the thrombotic complications were higher, and IVC filter complications were significantly higher on these patients that were getting these prophylactic filters inserted. Another study that clearly went against those guidelines is this Penn State Trauma Service review. They showed no significant change in their rate of pulmonary embolism. It was 0.7 versus 0.4. And they reported something very interesting, and became an issue after that, that 42 of all of the filters that were placed became permanent. I'm going to skip those because they're all variations of the same thing. Now, the ACCP guidelines that were published in 2008, about 5 years after those East guidelines, recommended against the use of IVC filters for thromboprophylaxis in the trauma patients. About 10 years ago, we looked at the IVC filter use in our own institution. We came up with some interesting conclusions. We looked at a 2-year period where 243 inferior vena cava filters were placed in our hospital. And what we found out was that only 54% of them had absolute indications, about 14% had relative indications, and prophylactic use was in 32% of these people. That was back in 2010. And interestingly enough, the service that was put in most of the prophylactic filters was the trauma service, following those old East guidelines. Well, we changed all of that, and after education with all the people, and considering that we only had 8.8% of all retrievable filters retrieved, we were able to decrease this number dramatically in the 5 years after this review. So why do we care so much about and we're against placement of IVC filters. There is a number of complications that are associated with IVC filters. I've listed here some. Deployment outside the cava in the iliolumbar veins. I've seen that not infrequently. Injury of the inferior vena cava filter, if you're going from, particularly if you're going from a jugular approach. I had one of these cases myself, where a wire injury on the right heart caused pericardial tamponade on a patient. Filter migration, filter erosion of the IVC, that's a much more frequently recognized phenomenon now with the retrievable filters. Insertion site thrombosis, not as common with the smaller devices that we're using now, but certainly in the past with the larger size devices, that was an issue. Inferior vena cava thrombosis, that's estimated to be up to 13% at 8 years, and then thrombus extension proximal to the filter, and an increased incidence of DVT on these patients. Is there a way to get pulmonary embolism despite having an IVC filter in place? And the answer to this is yes, it is possible. You can get PE from sites that are not drained by the IVC, such as the SVC or the right atrium. You can have small thrombi that pass through the filter. If you have a filter in an eccentric position, that facilitates even larger thrombi to go through when the tip of the filter is towards the wall of the cava. When you're having thrombosis and thrombus presence above the filter, certainly the filter was not going to help in these situations. And then when you're having collateral circulation from the lumbar or gonadal veins, this is one of these examples, where you're having IVC occlusion, but you have these large veins on the side, that can really become sources of pulmonary embolism. And I am not going to continue with these cases, but I want to show you this one case. This is a 34-year-old male who developed a right femoral vein VTE. He has chronic lymphocytic leukemia. He had pulmonary embolism. He was treated with therapeutic anticoagulation. And after a recurrent DVT, he went to an outside institution where they placed a retrievable inferior vena cava filter. He came to us 2 months after that insertion, and he was complaining of worsening abdominal pain, nausea, and vomiting. The pain was episodic, occasionally severe. He was diagnosed with mild acute pancreatitis, and then he had a CT scan that had some interesting findings. So if you look at the scan here, you see the inferior vena cava right in this area. You see the inner struts and then the outer struts that are completely outside of the contour of the inferior vena cava. There is two that goes towards the pancreas. There's one that's going towards the aorta, one that's going towards the renal vein. Keep those in mind. He had an unsuccessful attempt on retrieval due to severe pain. When we tried not to retrieve that filter, it was impossible for the patient to tolerate the pain, so we aborted that procedure. So then we did a hybrid procedure, and you can see we went in here, and all of these prongs that are coming outside the cava were released from the tissue surrounding them, but the one in particular was the one in the renal vein that we had to carefully remove because it appeared that it was pulling the entire vein up. You can see the posterior wall there with some of the struts going towards the posterior lumbar area. So we cut those struts from the cava, and you can see them, all the cut ones right there, using wire cutters, and then we were able to retrieve the filter from the top. This is another case of ours with filter preventing PE, but there is a significant amount of thrombus that is trapped in there, and all the flow of blood in the cava goes around the filter, as you saw in that conical shape. And then a suprarenal IVC filter with chronic thrombosis, as you can see here, those filters remain permanent there. Component embolization is rare, but has been described. Look at the inferior vena cava here. It should have a total of 11 appendages. It only has 9. One of them is through the right ventricle and causing a pericardial effusion here. And there is another, a second one right at the tip of the RV. You can see a filter that has embolized in the heart. That those are usually filters that are undersized or cavas that are oversized, and that's a consideration that needs to happen prior to insertion of the filter. So this study that we published back in 2013 was a review of the reports of adverse device events. It's the MOD database. It stands for the Manufacturer and User Facility Device Experience Database. And what it shows is that since the introduction of the retrievable filters, the amount of adverse events that are associated with filters numerically has increased. It's probably associated to a certain extent with the increased use of inferior vena cava filters. But more importantly, the number of perforations of the cava has increased, and the number of surrounding structures affected by the filter has increased. So based on some of the complications reported in 2010, there was a communication that came from the FDA saying that they received 921 device adverse events and that they were concerned, and their recommendation was that implanting physicians and clinicians who are responsible for the ongoing care of patients with retrievable filters consider removing the filter as soon as protection from PE is no longer needed. And keep that statement in mind, because that has led to a number of issues with litigation. And as you can see here, the advertisement on cases of inferior vena cava filter complication has gone up. This is a free case evaluation advertisement in one of the sites there. So since the FDA communication, look at the result. We have seen a gradual increase from 2003 to 2010, and then after that communication, a significant decline per year on the inferior vena cava filter use. The litigation trends, this is a very interesting paper that came out of Montefiore Hospital. It's a review of 156 cases that were drawn from the Westlaw database between 2000 and 2015. They excluded for several reasons 35 from the analysis, but on the other ones, 49 cases were involved in either a failure to place or a complication of an inferior vena cava filter. So the most frequent defendants here were internal medicine physicians and vascular surgeons for the inability to timely insertion of the filter, and more frequent claims, denied treatment or delaying treatment in 35% of the cases, negligent surgery in 24% of the cases, meaning doing it without any indication, and then failure to diagnose and treatment complications in 24% of the cases. So 17 cases were found for the plaintiff with a median award of over $1 million. And in 21 cases where PE was involved, that represented 43% of the cases, 19% were fatal, and of the fatal cases, 8 ended with a verdict in favor of the plaintiff. So inferior vena cava filter retrieval has remained a challenging task. A retrospective review back in 2010, 351 patients with retrievable filters, about 20 259 filters were available for retrieval in that study after they excluded 92 patients. 7 of these patients had an attempt to retrieve that was not successful. 47 were successfully retrieved, but more than 80% of the cases were not retrieved. What this study found is that whoever was consulted about that IVC filter after the filter insertion really affected the outcome of these patients. If the patient went to a medical consultant, like a hematologist, to deal with the rest of the VTE, 95% of the filters remain non-retrieved. But if this patient went to a surgical consultation, particularly a vascular surgeon, the retrieval rate was significantly higher. We did develop a retrieval program, and we still have it in our own institution. We have a dedicated nurse that keeps track of all the patients that have IVC filter placement, not only by the vascular service now, but by other services in the hospital. And we have been able to maintain a retrieval rate of over 50% for a number of years right now. Having that type of a dedicated VTE team clearly is very helpful, because a lot of these patients, particularly the ones that are treated for trauma, or some of the people that are treated by other services such as spine or oncology, they tend to be lost to follow up. Retrieval of IVC filters is not something that is free of complications. The reported procedural complication rates range between 0% and 20% in the literature. I believe that the truth is somewhere in between. I would say that there is a 5 to 10% risk on people that have IVC filter retrieval. And here's a list of the most common complication. It's either access site, jugular vein thrombosis, fracture of the limb with embolization, extravasation and hemorrhage from the inferior vena cava, caval thrombosis, caval dissection. I'll show you some of these cases. This is a great, by the way, this is a great review paper on retrieval techniques by Quenser. It was published on the CVIR Endovascular Journal about 2 years ago. So a couple of the types of the complications, if you can follow me along here in the pictures. This patient had the filter for about 11 months. They used bronchial forceps to grab the filter, but the filter angulation was such that they could not use the retrieval device. That's why they used the forceps. And the follow-up cavogram showed significant contrast extravasation. The good news is that even on patients that get this type of extravasation, usually it's self-limited and you don't really need to convert them to open repair, but you need to keep them, follow them, and support them until, they stabilize. Another case of a tilted filter that you can see here, if the patient developed hypotension and right-sided flank pain. The problem here was that the tip of the filter was close to the right renal artery, and this resulted in renal artery thrombosis and renal infarction. Another attempt here to retrieve a filter with the forceps. As you see, the filter then tilted downwards. There was an attempt to capture the filter from below. It was not possible to take it out. The filter got stuck in the iliac vein, and that required an open retrieval through an incision in the right common iliac vein. Another case of filter attempts on filter retrieval here with the complication. This was a suprarenal filter that was, I'm sorry, this was an infrarenal filter. They tried to retrieve it. The sling technique was employed there. Then the filter was pulled cranially, resulting in significant tilt and eventually entered the left renal vein. It caused acute left renal vein thrombosis and then required a placement of a suprarenal filter because this patient was not a candidate for anticoagulation for the acute thrombosis there. Another case here where a BART filter was attempted to be retrieved. During the retrieval process, there was component separation and component embolization. You can see here on the CT the component embolization in the right ventricle. And finally, a case that is not uncommon. I've seen this in personal attempts, not to the extent that it's been shown here, but certainly it's when you're trying to retrieve a filter that's been in place for quite some time. This is not an uncommon finding. There was a dissection on the cava that happened and extravasation. They utilized a balloon to try and improve the blood flow through that area of dissection. That was not successful, and then they had to put two large Z stents to keep the lower part of the inferior vena cava open and maintain good flow through that. So I believe that prevention of complication starts from the design and from the original decision to place a filter. Filter placement should be done for the right indications, might be carefully reviewed prior to any procedure. Retrievable filters are definitely more commonly involved in IVC perforation compared to the permanent filters. And the reason that I'm putting this there is a certain small percentage of the patient population that requires a permanent filter. These are people that will forever not be candidates for therapeutic anticoagulation due to whatever underlying condition they have, and require thromboprophylaxis for a long time. So there are some people that definitely require a permanent filter and should receive a permanent filter because the permanent filter's design is such that avoids some of these perforation complications. Appropriately timed IVC filter retrieval is critical. The sooner you remove a retrievable IVC filter, the easier the procedure is, the less well incorporated the prongs are, and it becomes a much simpler procedure. The longer you have to, the longer time passes until the time of retrieval, the more challenging the retrieval can be. I cannot emphasize enough the importance of placing an inferior vena cava filter appropriately with a minimum tilt, with no tilt if possible. That makes the retrieval process again a much more easy procedure. And then, of course, continuous structural design of the filters is required to prevent some of the complications that we're recognizing. Here is some of the new ideas. This is an absorbable filter design that you can see here. This is a filter design where over time, the conical area that you see in the middle, and it's being held, with an absorbable suture, opens, and then the filter becomes actually a stent that prevents clot trapping and maintains patency of the filter. I'm going to leave this and I'm going to go to my final consideration, so I will leave a little time for discussion. IVC filters are indicated for a small percentage of patients with acute proximal DVT who have contraindications to anticoagulation. Retrievable filters should be preferred in these patients unless the contraindications to anticoagulation are permanent. There is a permanent indication for an IVC filter on these people. Anticoagulation should be initiated after IVC placement when it is considered safe And once you have somebody on therapeutic anticoagulation, IVC filter should be removed soon thereafter. In general, IVC filter should not be used as primary thromboprophylaxis for high-risk surgery and trauma patients. I think that principle has been well embedded in recent years on physicians' minds, and the prophylactic use of filters has decreased dramatically, and I believe it accounts for a significant number of the decreased filters that we're utilizing. And with these thoughts, I will close and I will ask for any questions from the audience. I'm going to open my chat in case that you want to send your questions on the chat, or if you want to just unmute your microphone and start the discussion.
Hi, this is Zoe, and I'm sorry if you did mention this. You talked about a relative indication for temporary filter for catheter-directed thrombolysis.
Yes.
What about the newer ClotTriever, the ones that morselize the thrombus? What are your thoughts on needing an IVC filter for those? Do you feel that those do not impart the same risk as the catheter-directed thrombolysis?
That is a great question. I will tell you, when I started doing catheter-directed thrombolysis and pharmacomechanical thrombolysis, we used the angiojet device back in the days, because that was the only thing that we used. I used to put an IVC filter, on every one of these patients. And the reason was, you did not want to cause any problem, during the time of a procedure that you were doing to improve these patients' symptoms. Gradually, particularly when catheter-directed thrombolysis was a big component, if you will, of our treatments, I went away, from placing a prophylactic filter. Now, with these new devices that you are describing, I think that serious consideration needs to be given to the thrombus load and to the experience that each physician has with these. The safe answer is put the filter and take it out, like once you're done with the procedure. It's definitely the safe answer. But I know that there are people that have good experience with that, and particularly if you're using suction devices as part, of your thrombolysis, you may not necessarily need that filter in every patient.
Okay, thank you. This was a wonderful talk. But I will sure other people have questions. Do any of the fellows have questions they want to ask? Let's see if anyone's got their hand raised. No? Okay. I think you probably answered everybody's questions with your talk. It was a wonderful and detailed talk. Thank you so much. And it went very well next to our previous talk last week. So thank you so much.
Excellent. So I wish everyone has a great weekend.
Yeah.
And thank you for the kind invitation.
Okay. We'll see you hopefully at AVF in Orlando.
Absolutely. Take care now.